we're back at Camp Fiver here with Phoebe, the ski dog, and on the river trail this time. And topic this week is drugs for mental disorders. How do psychologists identify mental disorders in the first place? They use the medical model, right? What you're looking for is symptoms of an illness. Symptoms of something that's out of the norm, out of the regular normal homeostasis of the mind and body, particularly the mind this week. What types of mental illness exist out there? Well, we need to go to the Diagnostic and Statistical Manual of the American Psychological Association, now in the 5th revised edition, DSM-5-TR. And in that edition, you will find a number of mental illnesses that have been diagnosed over many, many years of observation and treatment by psychologists. They basically break down into 3 categories. You've got what was once referred to as neuroses, now referred to as anxiety disorders. These are disorders such as panic disorder, social anxiety disorder, phobias. No, there are many, many, many phobias, from agoraphobia, fear of the outdoors, to claustrophobia, fear of being too close, closed in, to hundreds of other potential phobias, fear of flying, fear of spiders, etc., etc. Specific phobias. And then there's illnesses such as OCD, or obsessive compulsive disorder, where somebody has difficulty with a routine without following that routine exactly. There is PTSD, post-traumatic stress disorder, a result of a stressful incident that the mind is trying to clear or protect the body from. And there are generalized anxiety disorders as well. Another type of mental illness is psychosis. Psychosis, probably the most typical psychosis, is schizophrenia. In fact, that is a psychosis that, when a symptom is difficult to determine what's causing it, may be alerted. So, other than schizophrenia, there are a number of other psychoses, ranging from the sociopathy and psychopathy, general unwillingness to participate normally in society and see other people as valid human beings, perhaps, to illnesses such as narcissism, malignant narcissism. I can think of one person with that disorder, and others. And then there are mood disorders. The mood disorders are perhaps the most common. Well, perhaps anxiety disorders are as common as mood disorders, but here we're talking about clinical depression, that feeling of depression isn't sadness per se. It's really more a lack of feeling, an emptiness, if you will, often reported by those with clinical depression. All right, moving here. Watch my glide. There's bipolar disorder. Bipolar disorder is a movement between depression and another type of disorder, which is manic disorders. Manic disorders are when people experience a kind of intensity in their daily life around what would normally not create such intense emotional and perhaps even physical responses. So bipolar is a combination of depression and mania, usually going back and forth over a period of weeks or months between those two extremes. All right, ready, pup? Okay. So these are the disorders that are being treated with drugs today. What drugs are being used to treat these disorders? Let's take a look. All right, before we take a look, I'm going to have to get down this hill. It's a pretty steep one. Okay, here we go. Woo! And down we go. Okay, so with treatment, in the past, it was often very common to simply sedate the patient. Sedate the patient with some kind of narcotic. There were a number of depressant narcotics or sedatives that have been used. We'll cover some of those depressants when we get to that chapter in week 8 or 9. And that it was a common response prior to the 1950s. It was usually either sedative or some kind of shock therapy. Initially, insulin shock was used. That was where the blood sugar of the patient would be deliberately lowered until they went into a convulsive shock state. Any diabetic who has missed their insulin shot may be familiar with that. Not a pleasant or good response of the human body to reach that state. But it did, in some patients, moderate the psychopathic or anxiety symptoms of the patient. But in the 1960s, it was found to be not clinically supported. Another type of shock therapy is electroconvulsive shock. Getting electrical shocks to the point where the body does convulse, and that has found to be effective as well temporarily for the treatment of mental illness. The shock therapies or the sedative therapies were really the only way in which physicians had an ability to affect mental illness until the 1950s, when a new class of drugs was discovered called phenothiazines. Phenothiazines are a type of drug that suppress the dopamine systems in the patient. They are dopaminergics, and particularly they are used for antipsychosis treatment, not necessarily for antidepressant therapy. There's another classification of drugs that we'll talk about, or really 3 classifications that we'll talk about when it comes to depression. But the phenothiazine antipsychotics were discovered in the 1950s. Sometimes they're called tranquilizers or neuroleptics. And they produce the effects that sedatives did without the sedation, which was, quite an important advancement in the treatment of patients. Heads up, Pete. There we go. Whoa. Logs underneath here. Snowpack is getting light. Spring is coming. It's a sunny day. Okay. So the phenothiazine class of drugs, they basically break down into 2 types of typical and atypical phenothiazines. The typical phenothiazines are those which emerged in the 1950s, and then a whole new classification, the atypical phenothiazines, came about in the 1990s. Some of the names of these drugs a little bit difficult to remember, so I'm going to get out my notes here and we'll read a list. The atypical phenothiazines would be those like clozapine, risperidone, quetiapine, and olanzapine. You notice there's an APINE at the end of those drug names. Typical phenothiazines break down into chlorpromazine, promazine, and fluphenazine. Then there's another category of typical antipsychotics called butyrophenones, and those go under the generic names haloperidol. The brand name of that one is Haldol, droperidol, and penfluridol. So note the ending there of RIDOL being common to the butyrophenones. Then there are TXNs, including thiothexine and flupentazole. No common ending in those, but each one of those are classified as antipsychotic or psychotropic drugs used to treat psychoses. Okay, here we go. All right, so the mechanism of action of these psychotropic antipsychotic drugs is, as I said earlier, the dopamine receptors, the dopamine neurotransmitters. These are dopaminergic drugs, meaning that they act on the dopamine neurotransmitter, and they are known to act on the dopamine neurotransmitters because of a particular side effect that occurs in patients that are taking these antipsychotics, and that's called pseudo-Parkinsonism. Now, if you're at all familiar with Parkinson's disease, it's an illness that involves the nervous system and produces symptoms such as shaking, tremors, and other symptoms that are common to the illness and common to those who are taking dopaminergic antipsychotics. Okay, I gotta get down there somehow. Ooh, this is tricky. Not enough snow. Look at that. Come on, Phoebe. The mechanism of action is probably more complex than simply immediately acting on the dopamine receptors like a drug such as cocaine would, for instance. But we know that because there's a time delay between the point at which the drug is taken and the symptoms of psychopathy start to be reduced, and it starts feeling more normal. Oh boy, tricky. Here we go. All right, got over that. Side effects of these phenothiazine antipsychotic drugs are allergic reactions, photosensitivity, a granulocytosis or cytosis, that's low white blood cell count, movement disorders such as tremors, muscle rigidity, shuffling walk, a mask-like face, inability to work facial muscles completely. That is the pseudo-Parkinsonism symptoms I spoke of earlier. And another physical condition called tardive dyskinesia, which again leads to shaking and other very noticeable and curious symptoms. Those often emerge after long-term use of the antipsychotics. Whoa. Okay. This is tricky. Whoa, this is tricky, baby. Gotta get down there somehow. How are you gonna do that? Alright, let's just get down there and then we can keep moving. This is not how you're supposed to ski. As far as long-term effectiveness as antipsychotics go, the drugs are only good if they're being taken, obviously. They will only treat the symptoms when taken. So one of the difficulties in treating psychosis is maintaining treatment patterns for the patient. So it's important that patients regularly take their medicine. It's important that patients continue taking the medicine even if they're feeling well, which is one of the difficulties. Often people who start feeling better think they don't need the medicine any longer, and then their symptoms return with stopping the antipsychotic. Other side effects in children, there can be weight gain and metabolism changes. The elderly can lead to dementia and potentially cardiovascular illness as well. So there is some risk for young and older patients in those areas. But the classification of antipsychotics has been so useful in the treatment of psychosis that I believe it was around the point at which those medications started to be used in the 1950s that admission to mental hospitals for mentally ill patients with psychosis was the last years. The 1950s were the last years that admissions to mental hospitals were increasing. After the 1950s, admissions started to decrease significantly because of the availability of treatment at home and treatment with these drugs. There's no indication that conventional or typical antipsychotics are any worse off or different than the atypical newer antipsychotics. It's very much a individualistic effort to find the right drug for the person, for the mentally ill patient. So it's wise to work with a doctor, of course, to find just what the right drug is. For the doctor to work with your patient to find just what the right drug is for treatment of their psychosis. Okay, let's move on to mood disorders and antidepressants. Antidepressants are not working on the dopamine systems, but rather, more likely, are going to be functioning on the serotonin neurotransmitters. Antidepressants come in three types, three categories. They're the MAOs, monoamine oxidase inhibitors. There are the tricyclic antidepressants, and there are selective serotonin reuptake inhibitors, or SSRIs. Each one has a particular way in which they affect neurotransmission and what neurotransmitters specifically they are affecting. As we learned in Chapter 4, there are over 100 different neurotransmission binding receptors in the brain, and so many of those are different versions, if you will, of the main neurotransmitters that we've learned about. Serotonin, I believe, has at least 7, if not more, different versions. So that's what the selective part of selective serotonin reuptake inhibitors is about. Monoamine oxidase inhibitors were discovered when it was used for tuberculosis, a physical illness of the lungs and body. And people taking that, come on, this way. And people taking those found their mood to be elevated. And they work on 3 different neurotransmitters: norepinephrine, serotonin, and dopamine. But unfortunately, they have toxic side effects and are not used very widely because of that fact. Tricyclic antidepressants also work on those same 3 neurotransmitters, norepinephrine, serotonin, and dopamine, by inhibiting uptake and thereby leaving more of those neurotransmitters in the synaptic cleft to bind and therefore increase levels of those neurotransmitters in the brain. They were discovered when researchers were working to find a better phenothiazine, and they discovered that drugs such as one called Elavil, for instance, were also improving mood. So that has been fairly widely used, but more likely to be used are the serotonin reuptake inhibitors and selective serotonin reuptake inhibitors. There are 2 classifications there. And those would be classic drugs such as Prozac and Zoloft. All right, hi, I'm back. My battery ran out right around the point I was talking about selective serotonin reuptake inhibitors, so I'll continue here at the lodge, i.e. my patio. So regarding the SSRIs, like Prozac or Zoloft, these drugs are frankly only slightly more effective than placebos, just regular old sugar pills, what we talked about in chapter 5, a drug that isn't a drug. A bit surprising given how much of this medication is prescribed these days. Since the 1990s, it's been a go-to medication for psychotherapists to prescribe to their patients, initially entirely replacing cognitive therapy, and that's somewhat problematic given that they are only slightly more effective than just a non-drug, a sugar pill. In the late 1990s and early 2000s, it was quite clear that the FDA was noticing suicides in relationship to SSRIs like Prozac, especially in children and adolescents. Children and teens taking Prozac were more prone to suicidal tendencies than those not taking the medicines, even those with clinical depression. So that is something to be a risk factor to be very aware of in prescribing those medications. The mechanism of action of SSRIs like Prozac and Zoloft appear to be that norepinephrine or serotonin are being affected, and that's very similar to the other antipsychotics as well, the phenothiazines. But it's not entirely certain how these antidepressants work. Even clinicians and those who are prescribing them aren't entirely sure how they work because there's a lag period before there's an improvement seen in patients. And that suggests that there's a much more complex mechanism going on in the brain with neurotransmission. As accumulation of these drugs starts to occur, they do seem to have some effect on mood elevation and a reduction in symptoms of depression. Side effects with SSRIs are clear. With long-term antidepressants, generally, you see side effects having to do with sexual problems, with weight gain, and sometimes with a flattening of mood, where there isn't that sense of despair, perhaps, that goes along with clinical depression. There is also no great euphoria or joy seen in patients who use these long term, and that can be in itself clinically problematic. One therapy that is, in fact, most effective for treatment relieving severe depression, those with the most troubling clinical symptoms, and that works very rapidly, unlike drugs, which take some time to work, is electroconvulsive therapy. It was my impression that this kind of therapy, electroshock therapy, was out of vogue these days, but in fact it is still being used, and is a better treatment choice in cases with a high risk of suicidal ideation, and these treatments can be used in conjunction with the drug treatments so that they can be used less frequently than might be necessary otherwise. Consequences of drug treatment for mental illness are pretty clear. The number of people in mental hospitals, as I mentioned earlier, has declined significantly since the 1950s. Part of that has to do with the drug regime, part of that has to do with social programs and social services being cut, but they kind of reflect each other in a sense. However, there has been development of outpatient community mental health programs that have been set up to treat patients closer to home in a more natural environment and at less expense to the state than the more classic mental hospitals of the past. Other consequences include changes for psychiatrists. There's less time spent doing psychotherapy, almost no time back in the 90s and early 2000s, but since then it's been clear that drug regimes alone have not solved people's problems. So a combination of psychotherapy as well as drug treatment is more typical today than in the past. There have been civil rights issues related to hospitalization. You can't keep somebody in a hospital indefinitely without violating their constitutional rights. So that has been mediated by the drug treatment. There has to be periodic review of a patient's status if they are hospitalized in order to determine if the patient presents a danger to themselves or to others. And that is an important aspect of the civil rights relationship to mental illness. Problems that develop may have to do with, again, patients stop taking the medication once they are released from hospitalization because they feel better and don't realize that continued treatment may be necessary. And unmedicated patients may still be too ill to care for themselves and may be a risk to themselves and to the public. As more people have moved from hospitals to the street, there is a greater potential for jail time being served or homelessness emerging as a result of that exit from the hospital. And more mentally ill persons are jailed each year than are admitted to state mental hospitals. So that seems to be somewhat problematic. In addition, 1/3 of all homeless people are have some form of serious mental illness. 1/3, it's less than half, but it's still a significant proportion. And you have the situation where people with suicidal ideation and who may not have the means to carry that out, turning to the police as a form of committing their own suicide. Suicide by cop is what they call it colloquially. And police are seldom trained to deal with mentally ill people. This became an issue several years ago during the pandemic, certainly, but it has been an issue before and since then. And I encourage you to take a look at the link I have on the last page of the notes there to an NBC story in 2021 about an increase in that outcome. So that pretty much wraps up this chapter for drugs having to do with mental illness. And that allows me to turn to High Price, Chapter 7, Choices and Chances. This chapter, again, like the last chapter, highlights Carl Hart's history in high school, takes him up to his senior year in high school, and quite disturbingly shows some of the errant behavior of his past. He was a thief. He stole batteries from garages in order to resell them, and he talks about a very close call that he had with one heist that he was undertaking. And interestingly, though, it also focuses on the fact that he was doing this simply because of the situation of poverty that he was in, and many of his friends and family were in. Not that that is an excuse, and he says that quite clearly in the chapter, but he had a legitimate job making something in the range of $4 an hour, I think. But as we all know, minimum wage jobs these days do not cover costs necessary to live the most basic lifestyles. And so, like many people today, he turned to crime in order to supplement that income. He regrets that, certainly, as he writes about in the chapter, but found it at the time a necessary and, frankly, somewhat normal mode of operation, if you will, of his daily life. What gets him out of that situation is a math aptitude test that he takes. He notes earlier in the book that he kind of took a liking to math. He was somewhat good at that area of scholastics, and because of that, he did very well on an aptitude test that the military gave in order to look for potential candidates in his high school for service. And he went through and examined the different branches of the military and focused on the Air Force as the one that was what he felt was the most legitimate. And so eventually, by the end of the chapter, he does apply to the Air Force as an after-school plan. And also helped him to embrace critical thinking skills, meet new people, see the world, and really change his life in a direction that led him into becoming a neuropsychopharmacologist at Columbia University. That's the chances part of the chapter title. It's very clear that he says that it was a kind of a luck situation that got him to take that test and got him eventually into the Air Force. Without that one kind of change of path in his life, he may have ended up like some of his friends and not in a very good place. And so he gives a lot of credit to chance, but he also notes, and I think it was a really interesting quote, can't remember the quote exactly, but it had to do with the notion that luck favors those who are prepared. And so without being prepared, those chances that might pop up would not have materialized into anything. He would not have capitalized upon them or been able to capitalize upon them. So the idea that luck is something that might skew one's path in life one way or another is modified by the fact that he was prepared, that he did the hard work that it was necessary to do in order to embrace that opportunity, and then for his life, get him into the Air Force and eventually into a college career. So do your work, do the best you can, be prepared for when those opportunities arise for you that may be chance occurrences so that you can capitalize upon them and move yourself forward. I guess that's a good lesson from this chapter. Okay, assignments for this week. There's a bi-weekly journal on this chapter and the previous, chapters 6 and 7 of High Price, so make sure you get to that. Another online media on phenothiazines and antipsychotics, antidepressants, drugs for mental illness. And I am getting back your concept papers this week, and you should move forward. If you're in the SOCH 370 section, you should move forward with the next opportunity, the next assignment, and that has to do with research and writing an outline for the paper. That will be due close to the middle of the month, just before the spring break begins. So you have a couple of weeks to do some research and start learning more about the topic that you've chosen. If you have not chosen a topic and have not submitted a concept paper and you are in the SOCI 370 section, please get that to me as soon as possible, and I'll get some feedback to you so you can move on along with that research and outline assignment. Okay, everybody have a good week. Peace. Be well. Happy Lent. Happy Ramadan. And blessings to everyone. Thank you. Good night.